Hello, my name is Yael Manor, and I'm a speech language pathologist from the Movement Disorder Unit at Tel Aviv Medical Center and from Manor Academic College in Israel. And first of all, I would like to thank the organizers for inviting me to talk about voice in Parkinson's disease. So I'm going to talk about the normal voice production and then the voice in Parkinson's disease, the effect of levodopa and DBS on Parkinson's disease, on the voice in Parkinson's disease, and then the effect of gastroesophageal reflux disease on voice in Parkinson, and we'll end up with voice therapy for hypokinetic dysarthria. So the normal voice production, we need three systems: the respiratory system, the vibratory system, and the resonating system. So basically, air comes up from the lungs through the trachea. Air pressure builds under the vocal cords, cause the vocal cords to close together, and then the vibratory cycle starts. So at this point, the air becomes voice, which goes up into our resonators, the pharynx, the oral cavity, the nasal cavity. As can be shown in the stroboscopic video, so we see normal vocal cords movements, normal structure, and nice closure with nice vibratory cycle. So in Parkinson's disease, we know that almost 80% of the patients suffer from hypokinetic dysarthria. And part of the hypokinetic dysarthria is the voice disorders, mostly hypophonia, but there are also hoarseness and harshness and breathiness, monopitch and monoloud. So let's hear this patient who has a harshness of the voice. And this happens due to his using the false vocal cords, which they are compensating on the gap between the two true vocal cords because the closure is incomplete. In the other example, I would like you to hear this patient that the voice diminish gradually and become very hypophonic and very breathy due to the hypokinesia and the both closure of the vocal cords. Okay. And in order to see this, in these patients, it's endoscopic examination. So you see the closure of the vocal cords and there is a gap between the vocal cords where they cause some vocal hoarseness. So how does the medications and the levodopa affect the voice in patients with Parkinson's disease? Definitely, we know that levodopa improve rigidity and the bradykinesia and the motor symptoms in Parkinson's disease. But in voice, it's a little bit different. It was found when patients took levodopa, there was an improvement in the restrictive respiratory parameters and decrease in the rigidity of the laryngeal muscles. On the other hand, when used the levodopa for a long time, it was demonstrated complications such as dystonia of the laryngeal muscles, the oromandibular area, and respiratory dyskinesia resulting in shortness of breath that definitely affect the voice production. In a review article that was done in 2018, it was concluded there no evidence that treatment with levodopa could improve laryngeal function and vocal intensity when patients were in on states. However, reduction in voice tremor and greater vibration in the amplitude of the vocal cords was noticed when patients were in on states. Well, it is well known regarding DBS and the effect on the voice production. There is general agreement among experts that ST and DBS can result in decrease in speech intelligibility. So regarding the voice, there is a discrepancy. Both improvement and deterioration were reported in studies employing perceptually derived measures of voice quality. And this include the tools like the voice handicap index, where the patients report about how the voice affects his life on 3 parameters: the functional, physiological, and emotional. And there is the GRBAS, that where the clinician evaluated the vocal quality of the patients. It's also well known that most common DBS-induced speech and voice disorders are the breathiness and the strained of the voice. In one of the articles, loudness increased significantly with ST and DBS stimulation was found, but on the other end, the speech intelligibility was deteriorated. So this was kind of discrepancy between these two data: better voice production, but reduced speech intelligibility. In another study, they examined the characteristic of the laryngoscopic findings in the vocal mechanism of patients with Parkinson's disease, and they did subjective measurements too. So in this study, 47 patients participated. 22 patients had bilateral ST and DBS, and 25 patients were treated by dopaminergic medications, and they compared between the two groups. So regarding the GRBAS, in all the parameters, the overall grade, the roughness, the breathiness, the asthenia, and the strength of the voice, the group who took the medication had greater results than the DBS group. The same for the VHI. The meds group got a better score than the DBS group. When they look in both groups in their larynx, they find more disorders, characteristics such as incomplete glottal closure, hyperreduction of the false vocal cords, and anterior-posterior high comprehension in the DBS group than the patients who took medication. However, the less tremor for the vocal cords were shown in the patients who underwent bilateral ST and DBS. Regarding reflux, a gastroesophageal reflux disease, it's kind of disease that really can affect the voice, especially when we talk about laryngoesophageal reflux, where the voice, where the citrus come up from through the coicoesophageal sphincter and can go into the larynx, and this can affect and harm the vocal cords, cause them edema, and of course distort their voice, because then the mass of the vocal cords changes and the vibrating cycle is also distorted. And it's known that the presence of Parkinson's disease increased the prevalence of the rates of the gastroesophageal reflux disease to 4.1 times higher than the age-matched controls. So when we hear the patient's voice, of course, we can always refer it to the hypokinetic dysarthria, but we also have to consider and ask the patient if he suffers from reflux or do the appropriate exam for this. The treatment is either behavioral, which the patient has to watch some diet and eat in certain times. And if this doesn't help, then there are some PPIs that can help to reduce the reflux. And finally, regarding voice and speech therapy, there is tremendous amount of research regarding the successful of the LSTBT program, which is well known all over the world. And this program focused on loud voice, a lot of effort, and really showed excellent result in speech intelligibility of patients with Parkinson's disease. Another program is the Speak Out program, where the patients learn to speak with intent. They're focusing to speak more clear, slow, and with a loud voice, and a cognitively focus on this parameter. And the other program, which is the EMST, the Exploratory Muscle Strength Training Program, is an exercise program designed to modify the physiological mechanism associated with exploratory tasks. So originally, it was developed to improve the swallowing mechanism by increasing the efficacy of the cough and the hyolaryngeal movement. But then patients who routinely exercise with EMST showed greater improvement in their vocal intensity. So those of you who have speech therapy in the Parkinson Center, I'm sure this exercise is very familiar with this sound, long and and loud sound, where the patient is really focusing on increasing effort while producing his voice. So, as has been said, the human voice is the organ of the soul. So we want to continue to hear our patient's voice. So routine exercise of the vocal mechanism and the two vocal cords is very, very crucial in order to maintain and improve speech intelligibility. So thank you for your attention.